Welcome to the deep dive. It's really fantastic to have you sitting down with us today because whether you're a dedicated medical student or a junior doctor on rotation or even a senior clinician prepping for board exams, you are in exactly the right place.
Absolutely. It is a pleasure to be here. We have a genuinely fascinating subject ahead of us today, one that it really requires a precise integration of pathology, physics, and the law.
Yeah, and right off the bat, we need to issue our required disclaimer. This deep dive is a conceptual companion. It's designed to support you as you read Chapter 9 of Simpson's Forensic Medicine.
Right.
So it's here to help anchor the concepts in your memory, but it must not be used as a replacement for actually reading the textbook itself. You still have to do the reading.
You do. The textbook provides the comprehensive foundation you need for actual practice.
Yeah.
We're really just here to help structure that knowledge so it's memorable and exam ready.
Exactly. So our mission for this deep dive is to translate the forensic language of velocity and energy transfer and trajectory into clear medico-legal frameworks. We're basically looking at how physics leaves its imprint on human tissue.
Which is a brilliant way to phrase it.
So to set the stage, when we say firearm, what are we actually talking about legally versus, say, mechanically?
Well, in the UK, under the Firearms Act 1968, a firearm is defined as a, and I'll quote this, lethal barreled weapon of any description from which any shot, bullet, or other missile can be discharged. But what's really fascinating here is that lethality itself is a highly complex issue.
Oh, so.
Ultimately, whether a particular weapon is legally a firearm is decided by the courts, not just by clinicians.
Right. Because our job as clinicians is to interpret the injury, not to issue that final legal verdict. So to structure our thinking today, we can divide these weapons into two main categories, right? We have smoothbore weapons like shotguns and rifled weapons like handguns and rifles.
Good suffice it.
But the actual mechanics of how they fire, it's pretty similar across the board, isn't it?
It is. The foundational mechanics definitely cross over. The operator pulls the trigger, which causes a firing pin to strike a primer cup at the base of the cartridge. That primer explodes, and that ignites the propellant.
Which is usually a modern synthetic compound now, right? Like nitrocellulose.
Exactly. And as that propellant burns rapidly, it produces massive volumes of expanding gas. The intense pressure of that hot gas is what physically forces the projectile out of the barrel.
Now, I remember seeing a crucial conceptual anchor for this entire topic in the text. The equation for kinetic energy, that's Ke equals 1/2 mv squared, so mass times velocity squared.
And that equation is the absolute master key to understanding wound severity. Because velocity is squared, it is the dominant factor in energy transfer, and therefore subsequent tissue damage.
So speed matters more than weight.
Exponentially more. A bullet's speed is the primary driver. A high muzzle velocity military weapon will deliver significantly more kinetic energy to a target than a larger, heavier, but much slower bullet from a standard handgun.
Got it. Okay, I read a great visual metaphor in the text for how smoothbore weapons, specifically shotguns, how they discharge their ammunition. Since a shotgun fires a cartridge containing multiple pellets all at once, the text describes the pattern as an expanding cone.
Yes.
Does that accurately describe what's actually happening in the air?
It captures it perfectly. As soon as that compact mass of pellets leaves the muzzle, it starts spreading out into a long, shallow cone. And that expanding cone is the exact reason why range determination is so recognizable with shotguns. We can actually build a pretty solid pattern recognition framework based on how far the victim was from the muzzle.
Okay, let's walk through that framework for the listener, starting with contact wounds. If the muzzle is pressed directly against the skin, what does that look like on the autopsy table?
Well, you'll typically see a circular entrance wound that approximates the exact size of the gun muzzle. The skin edge will be clean cut. But the key finding here is what the gas does.
The expanding gas from the propellant?
Right. The hot gases from the discharge enter the wound, and they balloon the skin outwards, pressing it hard against the muzzle of the gun itself. This leaves a very distinct circular abrasion rim on the skin.
Oh, wow. What happens if that contact wound is over a hard surface, like the skull, where the gas can't just expand into soft tissue?
That's where things get dramatic. That trapped gas has nowhere to go. It reflects back off the bone and causes the ballooning skin to physically split open, creating these massive radial lacerations. You also find wadding, those are plastic or felt discs from inside the cartridge, driven deep into the wound track.
And the tissue color changes too, right?
It does. It's a fascinating detail. The surrounding tissue might appear cherry pink. This is caused by the carbon monoxide in the discharge gases reacting to form carboxyhemoglobin in the tissues.
So that's contact. Moving just a bit further away, we have close-range wounds, which are within a few centimeters of the skin. How does that presentation change?
At close range, the gases can escape into the air before hitting the skin, so you won't see that muzzle imprint anymore. But you will see severe smoke, soiling, singed hair, and what we call powder tattooing.
Tattooing.
Yes, tattooing occurs when unburnt or burning flakes of propellant physically embed themselves into the skin, causing tiny permanent burns. And unlike soot, this tattooing cannot be washed off.
Okay, then we hit the intermediate range, roughly 20 centimeters to 1 meter. This is where the text uses a very specific clinical descriptor, the rat hole or scalloped edge.
That's because the shot is just beginning to spread out from its compact mass. Because the pellets are separating slightly, the edges of the wound become irregular and scalloped. It looks almost exactly like a rat chewed a hole through the tissue. You might also start seeing separate, adjacent injuries caused by the plastic wadding opening up and striking the skin independently of the shot.
And at a distant range, anything beyond 1 to 2 meters.
You'll see satellite pellet holes appearing around the main central wound. As the distance increases, the central hole gets smaller and the satellite spread gets wider. Beyond 10 meters, there's no central hole at all, just a uniform peppering of shot across the entire body.
When a clinician is evaluating this spread in the ER, can they just use a standard textbook ratio to tell police exactly how far away the shooter was?
They absolutely cannot. And if we connect this to the medico-legal realities, specific range determination in court requires test firing the actual suspect weapon with identical ammunition.
Because every gun is different.
Exactly. Generalizing the range based merely on a textbook ratio is unreliable, and it will be completely dismantled in court by defense experts. There's another medico-legal pearl here regarding shotguns, too. Exit wounds are incredibly rare in the torso because the small pellets lack the mass and energy to pass entirely through the body.
But not in the head.
No, in the head, the sudden gas expansion of a contact wound can be literally explosive, often ejecting brain tissue and creating a massive exit defect.
Okay, so that's the expanding cone of a shotgun. But what happens when we look at handguns or rifles, where you just have one single bullet spinning towards a target? How does the injury change?
Well, rifle barrels have spiral grooves inside that impart a gyroscopic spin on a single bullet, stabilizing its flight. For the clinician in the emergency department or the pathologist, the core challenge really shifts to differentiation, telling an entry wound from an exit wound.
The classic entry wound is described as an inverted defect, right? Pushing the skin inward.
Yes, the skin is pushed inwards, and because skin is highly elastic, the hole is actually slightly smaller than the diameter of the bullet itself. You'll also see a classic abrasion collar or rim around the hole. This is caused by the friction, heat, and dirt of the bullet rubbing against the skin as it indents and penetrates.
Do we still see those range markers, the soot and the tattooing we talked about with shotguns?
We do, though they present around a single defect. A contact wound might show splitting over bone or a physical imprint of the muzzle or foresight. A close-range shot, under 20 centimeters, will show soot, burning, and that permanent powder tattooing. And the shape of the hole tells a critical story.
Right. Circular versus oval.
Exactly. A perfectly circular hole indicates the weapon was discharged at a right angle to the skin. An oval hole, perhaps with undercutting on one edge, tells you the bullet struck at an acute angle.
Okay, so the entry wound is pushing the skin in. Does that mean the exit wound is just the reverse? It's blowing the skin out?
Generally, yes. Exit wounds are generally averted. The skin is pushed out. They often present with split, stellate, which means star-shaped flaps. Crucially, there is no soot, no burning, and no powder tattooing on an exit wound because all of that material was left at the entrance or stripped away inside the wound track.
Unless it ricochets.
Right, at extreme ranges. Or if the bullet ricochets off a wall first, it loses its gyroscopic stability. It starts to tumble. That creates a highly irregular, atypical entrance wound that can sometimes be confused for an exit.
Which brings me to what seems like a massive diagnostic trap for clinicians, the shored exit wound.
It is a vital concept, and it causes constant confusion in trauma bays. If the skin at the exit site is firmly supported, say the victim is wearing a thick, tight leather belt, or they're leaning hard against a brick wall, the skin cannot push outward to avert.
So what does it look like?
The exit wound will look small, and the pressure of the bullet crushing the skin against the supporting surface can even create an abrasion rim. It will mimic an entrance wound almost perfectly.
That is terrifying from a diagnostic perspective. If a clinician misidentifies an exit as an entry, they might completely flip the trajectory of the shooting in the medical notes.
Which is why this raises such an important point about our role. The clinician must rely on objective, meticulous documentation of the physical presentation, rather than making speculative, definitive claims about entry versus exit without the full forensic context.
We can't just talk about the skin, though. We have to talk about what happens inside. High-velocity bullets don't just poke a neat hole through the body.
No, they don't. A low-velocity bullet might just mechanically disrupt the tissue in its direct path. But high-velocity bullets, like those from military rifles, transfer massive kinetic energy. They stretch the surrounding tissues radially outward at supersonic speeds,
Creating a cavity.
a massive temporary cavity inside the body. This cavitation effect can completely shatter dense, relatively inelastic organs like the liver, the spleen, or the brain, causing catastrophic damage far beyond the actual physical track of the bullet.
To illustrate just how critical objective documentation is, the text uses the 1963 autopsy of U.S. President John F. Kennedy. It honestly reads like the ultimate cautionary tale in forensic medicine.
The Kennedy autopsy is studied to this day, specifically for its procedural failures. The president's autopsy was performed hastily in a military hospital, not by specialized forensic pathologists. There was a profound lack of detailed dissection.
Didn't the surgeons alter a wound during resuscitation?
Yes, the surgeons at Parkland Hospital in Dallas had performed an emergency tracheostomy right through an anterior neck wound, altering its appearance. The pathologists later failed to dissect the neck to actually track the bullet path.
And I understand the contemporaneous notes were actually destroyed.
Incredible as it sounds, the lead pathologist burned his original blood-stained notes. Photographs were limited, and X-rays were not fully appreciated at the time. Because the initial clinical documentation was so compromised and disjointed, it created a permanent cloud of public doubt and endless conspiracy theories.
It is incredible how a lack of strict forensic protocol can literally alter history. Do modern reviews offer any clarity?
Modern forensic reviews of the original X-rays and skull fracture patterns have provided clarity, yes. The fracture lines radiating from the back of the skull confirm the fatal shot came from behind. Meticulous clinical documentation is paramount from the very first moment.
Let's shift gears slightly. What happens when the projectile isn't a standard bullet or a shotgun shell? What about air weapons? Do they follow the same rules?
Air weapons rely on compressed gas rather than expanding combustion gases. The entry wounds often look exactly like standard bullet entry wounds, complete with a central defect and an abrasion rim. However, because they are relatively low-powered, they rarely produce an exit wound. The pellet is almost always retained in the tissue.
And what about kinetic energy devices, or KEDs? Things like plastic bullets or baton rounds used by police and security forces in public disorder situations.
These impact devices are designed to be less lethal. The attenuating energy projectile, or AEP, used by UK police is a prime example. It's designed with a void in the nose cap. When it strikes a person, that void collapses, which extends the duration of the energy transfer and attenuates the peak force.
But the text is very clear that less lethal does not mean non-lethal. We have to look at this impartially.
We do. We must impartially recognize that while they are designed to minimize life-threatening injuries, if they strike vulnerable areas like the head, the facial skeleton, the thorax, or the abdomen, they can absolutely cause fatal injuries.
I was actually surprised to see industrial and agricultural tools mentioned in the text. Things like stud guns and humane killers.
Well, a nail from a power-actuated stud gun can create an entry wound very similar to a small-caliber bullet.
Yeah.
Usually, imaging or finding the nail solves the mystery. Humane killers, used in abattoirs, might use a captive bolt that punches into the skull and retracts.
Crossbows were mentioned too.
Crossbows are another fascinating outlier. If a field tip arrow is used and then removed from the body, the resulting circular or oval defect can mimic a bullet entry perfectly. Context and scene investigation are everything.
When you're looking at a body with a gunshot wound, the immediate question seems to be manner of death. Suicide, murder, or accident. How does a pathologist even begin to untangle that?
The forensic practitioner looks for sites of election. In suicides, these are typically accessible areas, inside the mouth, under the chin, the center of the forehead, or the dominant temple. Handgun wounds to the temple are almost uniquely suicidal, whereas multiple firearm wounds or wounds in inaccessible areas like the center of the back strongly suggest homicide.
The text also introduces the concept of activity capability, and this blew my mind.
It's a crucial reminder to never assume a wound is instantly incapacitating. Pathologist Vincent DeMaio documented a case of a young man shot in the chest with a 12-gauge shotgun at close range. His heart was, and I quote, literally shredded.
Wait, His heart was shredded, but he didn't die instantly. How is that physically possible?
The individual was capable of running 20 meters before collapsing. The oxygen already in the brain can sustain conscious, directed movement for several seconds, even with zero blood pressure.
20 meters. With a destroyed heart, that completely changes how I would look at a crime scene. You could find a body 60 feet away from where the massive blood pool starts, and you might assume he was shot from a distance, when in reality he was shot at point-blank range and just kept running.
Exactly. Severe damage to the brain or heart will lead to rapid death, but rapid is not always instantaneous.
I want to touch on the legal obligations of investigating these deaths. The text references a specific case regarding human rights law, Kaya v. Turkey.
Right. This case was brought before the European Court of Human Rights. It involved an individual shot dead in an incident involving state security forces. We look at this impartially to highlight procedural law. The court found that the government violated its obligation to properly investigate the death. The medical legal investigation was severely deficient.
What went wrong with the autopsy in that case?
They performed a hasty autopsy in the field. They failed to record the number of bullets, they didn't determine the range of fire, and they entirely failed to test the deceased's clothing or body for gunshot residue. It underscores that a proper, rigorously documented forensic investigation isn't just best practice. It is a fundamental human rights obligation when the state is involved in a shooting.
Since we're discussing mass trauma and state-level investigations, we should briefly touch on post-detonation environments and blast injuries. These often involve secondary ballistic trauma. The text breaks explosive trauma into 5 tiers. Let's see if we can work through them. If an explosive device goes off, what is the actual primary injury?
Primary blast injuries are caused solely by the transmitted pressure wave of the explosion. This wave violently compresses gas-containing structures, primarily rupturing the delicate tissues of the lungs and the gut.
Okay, so if primary is the invisible pressure wave, I'm guessing secondary injury is the physical stuff hitting you.
Yes. Secondary injuries result from flying debris, shrapnel, and environmental fragments acting as ballistic missiles.
And tertiary, would that be the person physically moving?
Tertiary injuries occur when the blast wind literally throws the victim's body through the air, causing blunt trauma when they strike a solid object or the ground.
Leaving quaternary and quinary.
Quaternary injuries encompass burns from the intense heat of the explosion. Quinary injuries refer to the clinical consequences of environmental or bacterial contamination post-detonation.
In a mass disaster setting like a bombing, a clinician is suddenly thrust into a massive triage situation. The World Medical Association uses a specific ethical color coding system. Red is immediate, yellow is delayed, green is minimal. But it's the black tag that seems the most difficult to process.
The black or expectant category. These are patients who are either already deceased or who have such extensive catastrophic injuries that they simply cannot be saved with the limited resources available.
Ethically, how is a physician supposed to navigate telling someone they can't be saved?
The World Medical Association guidelines are clear. Ethically, it is acceptable not to persist with treatment beyond emergency care for expectant patients in order to save the maximum number of salvageable lives. However, this raises an important question of human dignity. The physician must provide those expectant patients with compassion. They should be separated from the chaos if possible, provided with appropriate pain relief and sedatives, and accompanied so they do not die alone.
To summarize our deep dive today, interpreting ballistic trauma requires immense clinical precision. It requires an understanding of physics, rigorous pattern recognition, and above all, restraint. You cannot overinterpret a wound without the full forensic context.
Remember the UK's General Medical Council, or GMC, guidelines. As a clinician, you have a duty to report gunshot wounds to the police. Evidence preservation begins the moment the patient enters the trauma bay. Do not discard clothing. Keep excised skin. Preserve any wads or bullets recovered during surgery. Establish that chain of custody early.
I want to leave you with a final provocative thought to mull over. Think about the sheer resilience of the human body. We define death as an instantaneous event in popular culture. The bullet hits, the bad guy drops. But as we saw with the concept of activity capability, the human body can absorb catastrophic kinetic energy, a shredded heart, a disrupted frontal lobe, and still propel a person forward for seconds or even minutes. How does that change the way you picture a crime scene when the victim is found far away from the weapon? How does it challenge our fundamental assumptions about the transition between life and death?
It is a profound reality of forensic pathology.
Let's lock in everything we've covered with our rapid recall single best answer prompts. I'll read the question, we'll give you a beat to answer, and then we'll reveal the correct response and the reference area. Here we go.
Yeah.
Question 1. What mathematical factor is most responsible for the massive tissue cavitation seen in high-velocity rifle injuries?
We'll give you a full 3 seconds to think.
1, 2, 3. The answer is velocity. Kinetic energy is proportional to the square of the velocity. Remember, Ke equals 1/2 mv squared. You can revisit the types of firearms section for this.
Moving to question 2. You observe a shotgun wound with a scalloped rat hole edge. What range of discharge does this suggest?
Take 3 seconds. 1, 2, 3. The answer is intermediate range, approximately 20 centimeters to 1 meter as the shot is just beginning to spread. Revisit injuries from smoothbore guns.
Question 3. A contact wound over the skull often presents with a ragged, star-shaped laceration. What mechanism causes this?
Let's pause. 1, 2, 3. Expanding hot gases from the muzzle are forced backward against the bone, ballooning and splitting the skin. Revisit the sections on entrance and exit wounds.
Question 4. What is a short exit wound and why is it a diagnostic trap?
Think about the clothing. 1, 2, 3. It's an exit wound firmly supported by clothing or a wall. It fails to avert and may develop an abrasion rim, making it look exactly like an entrance wound. Again, revisit entrance and exit wounds.
Question 5. In mass disaster triage, what does a black or expectant tag ethically require of the physician?
3 seconds here. 1, 2, 3. It indicates the patient has non-survivable injuries given the resources. The physician must allocate resources elsewhere, but importantly, provide the expectant patient with compassion, separation, and appropriate pain relief. Revisit mass disasters, boxes 9.5 and 9.6.
And finally, question 6. What constitutes a primary blast injury?
Last one. 1, 2, 3. Tissue damage occurring solely from the transmitted pressure wave, primarily affecting gas-containing structures like the lungs and gut. Revisit the section on blast injuries.
Excellent work sticking with us through these concepts.
Thank you so much for joining us on this deep dive. Now, take this framework, open up Simpson's Forensic Medicine Chapter 9, and solidify these concepts for yourself. We will see you next time.